Okay, I think we are on. So let's dive right in. Cardiometabolic Health Journal Club number 2, all about time restriction. So as a brief background before Marko's article, so time restricted eating is a specific definition, and I've got that versus intermittent fasting. So intermittent fasting is if you're doing 24 hours or more of fasting at a time. So that's like a water only fast for at least a day. Some people might do that for, 1 day a week, 2 days a week, and then eat ad libitum the other days. And this has been popularized on a lot of podcasts. Jason Fung is a nephrologist in Toronto who's really big in this space and has a large following and has a specific clinic where he helps patients with fasting. He's written a couple of books about it. So the selling feature there is, if you want to reduce calories, why don't you just not eat? That's that's the best way to go about it. Plus, you'll save yourself money on groceries. So, I mean, what could be wrong with that? So time restriction often gets confused as intermittent fasting, but time restricted eating is actually inside of a 24-hour period where you have an eating window. And that could be like 12 and 12. So 12 hours eating, 12 hours fasting, which is the easiest kind of introductory point to do, or like 16 and 8, or people will even shrink it to have as much as a 2-hour eating window during the day. So that's the terminology. But the rationale is tracking calories is hard for people to do. It's often extremely inaccurate, and tracking time is a lot simpler. So if you just give yourself time guidelines, there have been a number of non-randomized trials where time restriction has been associated with weight loss. The problem with those studies is that most of those have lacked an arm for comparing calorie restriction, because the argument is if you time restrict, then you're going to have a natural caloric restriction because you're just eating during fewer hours of the day. So with that, I will stop sharing my screen and Marko can jump in and present the first article.
Thanks, Andrew. So as Andrew said, in terms of time restricted eating, there have been some randomized controlled trials, but they're usually fairly brief in duration. And the idea behind this study out of China was that they would compare time restricted eating with calorie restriction versus time restricted eating or versus just calorie restriction by itself. So, and the follow-up was out to 12 months. So it was longer than, kind of 12 weeks or something like that. So in terms of the specific question, and I guess I can probably share the New England Journal article. So I'll just, so this is the, there we go. So this is the New England Journal article. So in terms of the paper, the question was really, does time restriction plus calorie restriction diet reduce body weight over 12 months compared to just calorie restriction alone? And it was really good because it was a randomized controlled study. And they randomized patients to one of 2 interventions. And the restriction was between 8 a.m. and 4 p.m. For 12 months, and a calorie restriction of about 15 to 1,800 calories for men and 12 to 1,500 calories for women, with kind of a balanced overall intake, 40 to 55% from carbohydrates, 15 to 20 from protein, and about 20 to 30% from fat. Now, in terms of the intervention, for the first 6 months, these patients were actually given 1 protein shake per day because to get used to the overall kind of rigor of calorie restriction. And the dietary counseling was actually, it was very intense overall. So they were meeting with the dietitian on a regular basis, getting a lot of things. So in terms of the recruitment, let's just have a look. So we have the table 1 here. and those are the patients. So they actually screened in the supplement, you'll see, they actually screened quite a few patients, 1,300 almost. And they recruited these patients just randomly off the street with like flyers and stuff like that. They excluded the vast majority of them, not meeting eligibility criteria. And in terms of eligibility criteria, kind of acute or chronic viral hepatitis was one of them. The one thing is that there is actually a fairly high proportion of people with Hep B in Asia. Otherwise, diabetes, liver dysfunction, kidney disease, current smoking. Again, I think the prevalence of smoking in China is also higher. Cardiovascular disease within 6 months, GI disease or gastrointestinal surgery or bariatric surgery within 12 months, active participation in the weight loss program, and then kind of use of medications for weight loss. So there's quite a few exclusions, and they ended up randomizing 139 patients. Now, their rationale behind this is that they wanted to power the trial for a difference between the two arms of 2.5 kilograms of weight loss. And, you know, in terms of the inclusion, it was a BMI between 28 and 45. It was thought that this is clinically significant. I think it probably is. But, you know, in terms of any kind of, you know, what is the actual benefit of 2.5 versus 3 versus 2 kilograms, that's unclear. So 69 patients got randomized to the time-restricted eating, and 70 got randomized to the caloric restriction. In terms of the characteristics between the patients, half were men. They're equal between the two groups. Half were men. 30, okay, interesting. BMI about 31. And body weight was, you know, kind of 90 kilograms. That's fine. The other interesting things that I thought, you know, they actually captured the total amount of caloric intake per day, about 2,550 calories. But also they captured the daily eating window at baseline, which was about 10 and a bit hours, with a standard deviation of about an hour and a half, which means that, what, 25% or so were eating for the first quartile, you know, the outside of one standard deviation, we're eating 9 hours or less. And again, if we look at, you know, how meaningful is this intervention? You know, what could have made it better? I think it's important to note that theoretically, one could say that their daily eating window was fairly brief to begin with. So, in terms of the results, 85% of the patients completed a 12-month follow-up visit, which is reasonable overall in terms of weight loss and these kinds of things. In terms of the mean weight loss, you always see this in weight loss studies, is that there is always a very dramatic effect at the start, and then a less sustained effect down the line. So at 6 months, people lost 9.5 kilograms in time-restricted eating and about 9 kilograms in daily caloric restriction. By 12 months, they had actually regained some of the weight back, but the people in the time-restricted eating with the calorie restriction actually did not regain as much weight as the people in just the caloric restriction. And at this point, the difference between the groups was about 1.8 kilograms. So, okay, interesting. In terms of the rest of the kind of body things, they were all consistent with the body weight. So the BMI decreased, weight circumference, body fat, mean body mass, body percent. So all these were better in the time restricted, and they were better. They're slightly worse at 12 months compared to the 6 months. So it was interesting. In terms of the rest of the groups, we see that the absolute weight change kind of drops. It peaked about 4 or 5 months, and then slowly starts creeping back up. Now, is this an effect of the fact that they were getting a protein shake a day and then going? Probably not. I think that's less likely. I think this is what we typically see with diets. And quite frankly, losing, 8 kilograms, so that's 10% of body weight, that's very substantial. It's on the order of the same amount of magnitude that we see with things like the newer drugs like Ozempic. So that's a very good effect overall. In terms of the other markers, as one would expect, they did improve with weight loss. In terms of blood pressure, improved. None of them statistically significant. The cholesterol did improve. The HDL increased. The LDL decreased. Their glucose levels at 6 and 12 months were also, and the postprandial glucose, the insulin resistance improved. The overall, in terms of the studies, I guess, the strengths, one, I would say, it was good. It was blinded. So at least the trial, the observers were not aware of the group assignments. The groups were fairly evenly balanced. They have pretty good adherence. I mean, even up to 12 months, one of the flow charts on let's just have a look here. Adherence to the prescribed diet here, it was very reasonable, even out to 12 months. I mean, you see that there's a drop, but even up to 12 months, you had about 80% of the people adhering to the diet, to the prescribed diets, both in the time restricting eating as well as the calorie restriction. A little bit less so in the calorie restriction, but not that much. So it's very impressive in terms of their daily energy intake. Again, their baseline was around 2,000 calories or so. And then you see by the third month, that's kind of the nadir. People are really observant, certainly less than 1,500. And it slowly creeps up out to 12 months. The people in the calorie restricted diet were not as adherent to the thing. So, limitations. The trial was performed in China. This is actually very interesting to me. I don't know what the dietary patterns in China are, but they do talk about this. So this is kind of in a supplement. They talk about the representativeness of the study participant. I think in terms of sex and gender, age, race or ethnic group, well, the participants in the study were Chinese. The prevalence of obesity is higher among non-Hispanic Black individuals and relatively lower among non-Hispanic Asian individuals in the US. There's no question about that. However, if you look at it, what they talk about here is that in China, it affects 90 million individuals, which accounts for 14% of obese cases in the world. That may be true. However, China is very big. I Googled 1.4 billion people in China, which means that it affects 90 million individuals. That's only 6% of the population. That is drastically different than the States, than Canada. It's drastically different than non-Hispanic Asian individuals in the States. The prevalence of obesity in the state, it's massive. It's not even to the point where it's really to the point where it's not how can you define it as a disease state when it affects about 50% of people? And this is the issue, is that we have an intervention that, yes, was, kind of calorie restricted, but really what we have is it's an intervention that depends on the culture of the local place where it's that's kind of implemented. And in terms of calorie restriction and counseling about calorie restriction in China, where the prevalence of obesity is only 6%, where the diet is different, where likely the dietary patterns are different, and where the social stigma of obesity is likely very different than in North America, I think that this is a very, very different population of obese individuals in China versus in North America and probably in Europe to a lesser extent. The other thing that we should probably talk about again is the fact that people were using time-restricted eating between 8 and 4. And that's a third of the day, which again seems reasonable, but at baseline, they were really following 10-hour time-restricted eating. So the difference in decreasing the time of oral intake from 10 hours to 2 hours or to 8 hours, I think that's a minimally minimally kind of clinically significant intervention. The other thing that we need to talk about is the fact that I'm just going to stop sharing. I think is the fact that we had patients who were counseled very extensively in terms of caloric restriction in both arms. And it was huge. It was like every 2 weeks they were seeing with a dietitian. They had meal replacements provided for the 6 months. And even if the meal replacement itself, is not taken, it's actually when you get something mailed to your house every like 4 weeks, you're like, oh right, there's still this thing, right? So all these things are very intensive, very involved. And the whole rationale behind time-restricted eating is that it's actually very easy to counsel, and conceptually, it's very easy for the patients to understand. So those were kind of my overall takeaway points, in that, yes, time-restricted eating with calorie restriction does lose weight, and it's actually a fairly significant amount of weight. The cool thing is that it is less than the caloric restriction, and it's more sustainable than caloric restriction because people regain less weight at 12 months from the 6-month nadir. But at the same time, the sample size was very small. 139 patients is powered, this is basically just powered on weight, and they just said, 2.5 kilograms. The crazy thing is that it took them 3 years to recruit the patients, and only 10% of the patients who were screened were recruited. Again, this goes to show that the patient population of obese patients in China is very different and far less prevalent than the patients in North America.
I think there's a major healthy user bias built into this study because of the way that they recruited was based on flyers and pamphlets. And so who are most likely to actually volunteer themselves for a study? You've already got people who are interested in complying, and then they weeded out 90% of those people. So I think that's why you end up with a young, relatively healthy, but obese population. So I totally agree. I don't know how to extrapolate that to the population that we see with the 40+% of Canadians who find themselves in the obese range.
That's that's the biggest issue, is that I think these patients were very different, right? In terms of, a BMI of 40 is probably, let's say if you're 5.5 feet, it's probably around 220 pounds. And if you have 6%, only 6% of the population who are defined as obese, BMI of 40 is probably, less than 1%, I suspect, because
I can't remember. Was it only the one supplement that they provided, or did they provide like all the meals for these people?
Just the one supplement.
Okay. Yeah. But hugely resource intensive operation to do all of the counseling. And in our healthcare system in Ontario, that's like basically impossible to do. I'd actually be interested to hear from Judy from the nurse practitioner standpoint. So are you in like a ministry funded nurse practitioner clinic, or are you embedded in a different type of clinic?
The Women's Health Center is OHIP covered.
Okay. And it's a nurse practitioner led clinic?
Yeah, it's a joint between a nurse practitioner and a gynecologist.
Okay. And do you get funding for additional resources like dietitian, social work, etc.?
We don't currently have that, but we are active, like we're looking at it. Our family health team executive director is trying to get that pulled into it, to have dietitian and possibly exercise
Okay.
resources included in the clinic.
Yeah. So, okay. So you're connected with a family health team.
Yes.
Okay, gotcha. Yeah. So within the family health team model in Ontario, I think it's quite viable to have resources like that. And so in primary care, we really have and have not patients. If you're not lucky enough to be enrolled in a family health team model, then it's impossible. You're just not going to get those things. And it's up to, so you're kind of just asking patients, do you have insurance? Like private insurance, or are you willing to pay to see a nutritionist or a dietitian or somebody who can help you as an accountability partner? Because certainly in my experience doing a lot of lifestyle medicine practice, that's the key ingredient is we can only see people so often, like usually at 3-month intervals at most. It's the in-between time where you need to maintain and adhere to the plan, that they need somebody that they can communicate with and can help with accountability.
I'd even say that 1 year follow-up is pretty short, right? Like, I mean, the only other diet fad was, the restriction, the keto diet plan. Like, that's the one that actually extends out the most to 2 year mark. But pretty much the 1 year is the inflection point for most diets. So they kind of stop their data right around that nadir before most people fall off, which is tough. So going back to sort of that idea of sustained coaching in the background. I also think this is kind of like, I mean, I feel like what they did with some of their time restricted diet stuff is maybe even a little bit behind in terms of what we do now. Like there's a whole bunch of cross referencing between when you time restrict. So, is time restricting and letting them eat first thing in the morning a legit thing, or should you actually be time restricting later in the day? There are some great biological pathways that suggest if you do your caloric restriction and you do that later in the day, that's actually probably where you see your bang for your buck, as opposed to allowing yourself to eat your calories in the morning, right? So I think there's a bunch of stuff out there that is still unknown and uncertain for us. So they may have pulled out some of that benefit for what I think is probably valuable for time restricted diet stuff.
So my personal bias is breakfast is amazing. But there is also data, like there's data to suggest that eating a breakfast, especially that's protein rich, actually leads to caloric reduction over the remainder of the day as well. And so I'm not, yeah, I think you have to get down like to the level of people have different circadian rhythms and they have different chronotypes and they respond to different interventions differently based on timing. So somebody who's generally up later in the night is going to have a different response to late night eating than somebody who's an early morning person and they're shutting down and going to bed by 9 p.m.
So there's actually some real stuff coming out of a small little regional hospital in North Carolina, Duke, where they're actually following some of these like normal people and following a lot of their biological stuff in the background, right? So they're doing it's the calorie studies, like phase 2 stuff coming out there as well too. And I think that's really going to be the cool stuff for circadian rhythm tie-ins. What does fasting do in the right time? And I think that's really going to be the cool stuff as we evolve this. I really think this was just like an initiation stuff, right? Like the person who's eating 3,000 calories, yeah, drop it down to 2,000, please. And the person who's having, the Sour Patch Kids channel, wake up, maybe a few less Sour Patch Kids. Don't cut them out completely because they're too delicious. But
no, do cut them out completely. Yeah. Yeah, well, that's really interesting. And then I think you're really getting down to basically personalized approach for each individual patient, and that's what takes time, and that's where these population studies it's really hard to generalize that. Any other comments or questions about this one before we jump into the next?
I mean, having said that, it's you have people standard of care versus just time restricted eating for maybe 6 hours, right? and then you pick a time. Boy, how easy would that be to do? And you just weigh the one
What's
sip.
it's an easy clinic intervention, and that's the nice thing about it, is it's really easy to have that conversation with the patient to just say, well, what if you just only ate between these hours? Try
Yeah.
it. Let's see what happens.
Absolutely.
I think one of the limitations of the study is the amount of intervention and counseling that they had, because like you said, to the accountability piece is, okay, you can tell them to lower their calories, you can tell them at what time to consume those calories, but then you also, I feel, should be doing some studies to specifically look at the accountability. How much does that make a difference, and in what populations? Because they're, like you said, you're really going to customize the care. A lot of the women, for example, coming to the Women's Health Center, they're motivated individuals. I don't know how much accountability they need. Maybe what they need is the information. And that would be interesting to tease out in some of the.
Yeah, for sure. Some patients are much more activated than others are, definitely. Karen brings up a good point here. So we're hesitant to prescribe SGLT2 inhibitors or even de-prescribe them for patients who are being treated with a ketogenic diet because of the risk of euglycemic DKA. I don't think that risk exists with time restriction, because these patients are not going into nutritional ketosis. So I wouldn't worry about it in this population. There have been studies of intermittent fasting in patients on insulin for diabetes. And interestingly, because they were very worried about hypos for patients who are fasting for like an entire day at a time, and it was not a problem. So they dose reduced, but they actually found that they probably didn't need to dose reduce their long-acting insulin on fasting days. Of course, they're not going to be taking their short-acting insulin. But even in that case, even when you're intermittent fasting, you're not going into nutritional ketosis. So, I think you have to take it on balance. If a patient is really calorie restricted and they're losing weight very quickly, then I think we need to be careful about all medications with a diuretic effect, because somebody is, especially if you're carbohydrate restricting in the early phase, you're losing a lot of water from your muscles, because glycogen stores are being depleted. And so you can easily overdo it on diuretics for those patients. And so that's a scenario where we might want to lower doses or de-prescribe initially and kind of see where people shake out. Okay, so I will reshare. Okay, you can still see the correct screen?
You're still good, buddy.
I love it. Okay.
Come so far.
I know. It's been a challenge, but we're getting through it. Okay, so this is article number 2, effective time restricted eating on weight loss in adults with type 2 diabetes. So this is a very different population than the one that Marko just presented. So now we're talking about older patients with diabetes and more comorbidities. In terms of the study protocol, so they enrolled patients between the ages of 18 and 80 with the diagnosis of type 2 diabetes. A1C range is given there, and they also had to be obese with a BMI between 30 and 50. They excluded patients who had an unstable weight. So that is, if they asked them about the previous 3 months and if their weight had been changing, I think by more than 3 or 4%, then they were out. So they wanted people who were already at a stable baseline. Anybody who had an eating disorder, which could be triggered if they were already naturally restricting to 10 hours. So I wonder if in Marko's study that would have excluded even more people, because the baseline they were already naturally restricting. And then anybody working night shifts, pregnancy, and smoking. And this was a 3-arm trial, 1:1:1 ratio of time restriction, calorie restriction, and a control group. For each of those groups, the time restriction group was allowed to eat ad libitum between the hours of 12 p.m. and 8 p.m. So again, different than the previous study, which was between 8 a.m. and 4 p.m. So this is now second phase of the day time restricted window. But they had no dietary restrictions in that time. All they had to do was basically just log their eating times. The calorie restriction group, they were shooting for a 25% reduction from their total daily energy expenditure, which was calculated using this Mifflin equation. And that's important, and I will bring that up later on. They got dietitian guidance for a meal plan to help with that, and they had to log their food in an app to make sure that they were hitting their calorie targets. The control group was basically just told to stay where you are. And then all groups, in terms of how they were treated throughout the rest of the study, actually all met with a dietitian, though it's a little bit sketchy of what they might have actually learned from this person or people. And then they had the same test frequency, same measurements taken throughout the study. For medication management, they had an algorithm to adjust, in particular, insulin and sulfonylureas to lower the risk of hypoglycemia. That was the same for everybody. Everybody wore a Dexcom G7 continuous glucose monitor. And the primary outcome from the study was % change in body weight. And then they had a list of secondary, like metabolic outcomes. However, the study was not powered statistically to detect differences between groups in the secondary outcomes. And so those are all descriptive. For the results, so a very different looking consort diagram. They screened initially 127 people. 52 of those were excluded, mostly because they didn't meet criteria or they declined. And so they ended up randomizing 75 patients. So talk about sample size issues. This is an even smaller sample size. So you've got 25 people in each group. And that was based on their power calculations and estimated dropout rate, so that they wanted at least 21 people in each arm by the end of the study. And then just to show you how not blinding patients affects stuff, one person withdrew from the control group because they didn't want to be in the control group. So that's fun. For baseline characteristics, here's the table. So we're dealing with people in their mid-50s. 2/3 of the population are women. And this is a different ethnic population. So mostly non-Hispanic, Hispanic white and non-Hispanic Black patients. And this was done in Chicago. So high proportion of ethnic groups in the inner city where they were doing the study. The important thing to point out here is the medications at baseline. So in the time restriction group, you'll notice that there's a significantly more patients on SGLT2 inhibitors and GLP-1s, both of which, of course, are associated with weight loss. So that's more compared to either the calorie restricted or the control groups. For the actual results of the trial for adherence, so at baseline, the time restriction group was already eating in a 12-hour window. And so they were shrinking that to 8. But interestingly, the calorie restriction in the control groups were 10.5 hours. So similar to Marko's trial. And I'm very surprised by this, because most patients that I see in the clinic who have obesity are eating like 23 hours of the day. Like it's, they get up, they eat, and then they're having like a late night snack before they go to bed, and they sleep like 5 hours or something, and with, high AHIs, and it's just like, it's crazy. So I don't know where they're getting people who are already time restricting, but maybe they listen to the right, or follow the right influencers on Instagram. Nevertheless, they're different. So the time restriction group is different. So they had more time to restrict at baseline. So when they actually look at the caloric differences from beginning to end, the time restriction group had an average caloric deficit of 313 calories per day, versus the calorie restriction group was 197 calories per day, and the control group was basically nil. Recall that they were shooting for a 25% reduction, and this in the calorie restriction group is 11.8%. So they basically failed to have the actual intervention in the calorie restriction group to go as far as they wanted it to, by half. So that's very significant in terms of what we see in the rest of the results. So this is the take-home figure here. So this is a 6-month study, And the time restriction group for percent weight loss is down here. So they had the greatest weight loss, and followed by the calorie restriction group, and then your control group here. So both the calorie restriction and the time restriction groups were significantly different than the control group, but they were not significantly different from each other. Okay, so for the appraisal, the sample size calculation, they say, was based on an estimated 7% weight loss in the time restriction group versus a 3% weight loss in the calorie restriction group. I have no idea how they came up with these numbers, and it makes no sense to me. So I don't know why they would expect that time restriction would result in a 7% weight loss. That sounds very aggressive to me, versus calorie restriction at only a 3% weight loss. So more than likely, these numbers should be more like 5% each, and it maybe should have been a non-inferiority type trial. But by juicing the numbers further apart like that, you shrink the sample size that you need to detect a larger difference like that. So this is problem number one. So they were probably actually underpowered to detect a difference between those two groups. The participants themselves are not blinded, because I mean, how do you blind for this type of intervention? You can't. And then the groups may have received different counseling, because I can't imagine that the person who is doing their dietary counseling, they would also know, based on what the patients are telling them, what group they're in. And then the Mifflin equation, this is problematic because it has this, well, most of these equations do. They have a physical activity adjustment, but I'll show you why this is an issue. So if you want to calculate somebody's total daily energy expenditure, you pump it into one of these formulas. So the Mifflin equation is based on height, weight, age, and then has a modifier for activity level. So if somebody is sedentary, you get a BMR, and then, which is the basal metabolic rate, and then you multiply that by 1.2. So that's the activity modifier. Okay, so that gives you your total daily energy expenditure at baseline. For patients who are lightly active, that is, not doing much, but they're doing something 1 to 3 days a week, you multiply it by 1.375, which gives you a 15% lift on the number of calories immediately, versus somebody who's only moderately active for 3 to 5 days a week. And this is where a lot of patients kind of sit in this group here. You multiply it by 1.55, which gives you a 29% increase in calories on your total daily energy expenditure calculation. So if you're trying to give somebody a 25% calorie deficit and you find them in this group here, you're basically just going to bring them right back up to where they were before. So this is what, and the reason for this is there's a lot of known physiology now that your basal metabolic rate changes based on how active you are. So the more active you are, your basal metabolic rate adjusts because it wants to keep you in an isocaloric range. So patients will actually drop their BMR and consume fewer calories at their basal metabolic rate to account for the total number of calories that they're burning with activity. So if we calculate based on their activity, we're always going to overshoot the number of calories that we assign to that person. And that's why often we don't get it right, and people are not in enough of a caloric deficit. So I hope that's a reasonably clear explanation. Okay, so part of the other issue, so there's a baseline natural time restriction in the calorie restricted group, as I highlighted in the table. The difference between the medications is problematic. The calorie restriction group didn't hit their 25% restriction. And then we also relied on self-report for adherence and tracking and like 24-hour dietary recall to actually see what people were eating. So those calculations are, there's the whole Hawthorne effect thing where somebody's being observed, they're going to probably track the fact that they're doing what they're supposed to be doing, even though they might not be doing it. And then there's also the fact that the two intervention groups actually were not statistically different whatsoever. Okay. For relevance, so again, we bring up the ethnicity. So this is mostly Hispanic and Black populations, which are very underrepresented in Canada. So can we extrapolate to the mainly Caucasian populations that we see, at least in Southwestern Ontario area? Not sure, because we know that obesity definitely disproportionately affects the Hispanic and Black populations more so than Caucasian. So what we can say is that with time restriction, you might achieve a 3 to 4% weight loss over 6 months just by simply telling somebody that they should eat in less than 8 hours of the day. So, I mean, from a logistical, pragmatic standpoint, that's reasonable, as we already discussed. Calorie counting doesn't work very well. Like if you just tell somebody to eat within a certain number of calories, they're probably not going to be successful with that, unless you have somebody who's like really a numbers person. They love tracking stuff, which is the minority of people. It's unlikely to do anything useful for you. And then calorie targets must be calculated accurately in order to actually work. And so we saw that the patients were eating somewhere between about 1,600 calories a day in a population that's mostly women. So to promote weight loss for women, typically you need closer to 1,200 calories a day in order to really achieve enough of a caloric deficit in the obese, diseased population. And then, yeah, time restriction. So I didn't present it, but they looked at all of the secondary outcomes, and there were no differences between the groups. You know, even like between the control group and the intervention groups, there were no differences. So we can pretty much conclude, and this is kind of study after study now, that time restriction really gives you no metabolic advantage over caloric restriction as long as you're restricting enough. And that's that. Questions, comments?
I think so. I just, I hope you can hear me okay, Andrew?
Yeah.
Yeah, I just reviewed intermittent fasting recently, and the results of this study are more in keeping with what we typically see, with time restricted eating. I think the last study that Marko presented was, quite different from the typical results that we have seen. Typically, like there is really no difference between time restricted eating versus caloric counting. Is for the vast majority of the studies that we have seen. Even over short time interval, over short duration, like 12 weeks or so as well. I mean, it is a simpler suggestion, on our end to make, but at the same time, I think it does require resources to continue to make that, reinforce that message to patients, which is often not, like we don't have those resources available in our busy practices. That's the unfortunate reality.
Yeah, for sure. And I mean, this just kind of, it underscores that the reason time restriction can work is because time restriction is calorie restriction.
Exactly.
It's like the same issue we have with semaglutide is we think it's a magic medication, but it's inducing a ton of weight loss. And so if we were able to have a study that was done that actually compared a similar amount of weight loss through non-pharmacologic means, we would probably see basically the same outcomes for cardiovascular and metabolic benefits. That's my guess. It's just that semaglutide is doing it so effectively, but there's no additional magic to the fact that semaglutide just makes people eat less.
Yeah, I mean, that's what we see with bariatric surgery, right?
Yeah.
Exactly.
So I think that there's a potential bias of suggesting that time restricted eating does not have advantage over caloric restriction. I think the reality, as you said, is that time restricted eating likely leads to caloric restriction. I think there are probably advantages to both, and that you may, unlike the semaglutide, it's hard to tease out what individual advantages are based on the data of these last two things because of the overlap and because of the way things are done. But I think it may be incorrect to suggest that there is no benefit of caloric restricting. Like caloric restricting actually does some good things with respect to dropping your basal metabolic rate, right? So that might actually have benefit on downstream pathways, oxidative stress, all that good stuff, right? So I don't think we have information to separate the two. I do not think that they're equivalent. I think that practically they result in the same thing right now, both of which are good.
Yeah. So if you like, let's use insulin as an example. So metabolic syndrome, type 2 diabetes, people have really high serum insulin levels, and this is problematic for a lot of reasons. And we want to reduce the area under the curve of total insulin bombardment of the system throughout the course of a day. So carbohydrate restriction is one way to do that, but so is fasting. The question is, how long do you actually need to fast in order to see a significant reduction and exposure to the damaging effects of insulin and its downstream pathways over time? And a 16 and 8 setup is probably not enough. So fasting for 16 hours is unlikely physiologically to give you enough of an advantage. I think I think what I'm sort of assuming what you're getting at, Channel, but I think for those metabolic advantages, you're actually looking more at like an intermittent fasting approach where people are fasting for 24 hours or more to really see a change in physiology and maybe increase insulin sensitivity and reduce the total insulin burden over time.
Exactly. I think that's one of them. So I think insulin burden is one. I think what we're going to see is a billion metabolic pathways elucidated through various programs that are being conducted right now, and that will probably see a continuum of the value of longer fasting having benefits in addition to caloric restriction. I still think the caloric restriction probably has this benefit as well too.
I feel like you're dying to bring up mTOR and rapamycin.
Maybe, but I personally like metalloproteases, sir.
Okay. Do you have a glass of olive oil that you're sipping on right now?
No, I do have my AI and a whole bunch of case studies though.
Very nice. Okay. Any other comments or?
I think something that I'd like to add on to kind of like both of these studies is that you mentioned it in both Dr. Mrkobrada and yourself mentioned it that it's a lot easier to just time restrict, right? And seeing as I'm a calorie counter myself, I can tell you how exhausting it is to think of something, and I'm only one person, right? Especially if somebody has a family or other people that they're in charge of feeding, like kids or something like that. It's very, very exhausting to be logging this day in and day out. So I think that's great in terms of just it's one thing that you're accounting for, right? Which is time. And I think more so than like what type of diet would be best for all of these health benefits, it's what kind of like patterns and behaviors you can modify, which is one of them is time restricted eating. I think people work well with like if it fits your macros. I don't know if anybody's heard of that, but all these different behaviors that can be changed or implemented to make the diet more adherable to in the long terms will probably, in my opinion, and anecdotally, this is what I'm aiming for, will result in overall better health at a longer period of time.
Yeah, I agree. And so the way I describe it to patients is when we're talking about improving nutrition, there's quality, quantity, and timing. So quality is we want to change the actual dietary pattern that you're eating to more of a whole food type pattern. You can go plant-based if you want. I personally appreciate good quality animal proteins, and we have that conversation with patients. But if you're doing a whole food pattern, you're moving towards foods that have lower caloric density. And so that alone will result in a calorie restriction. Then in terms of quantity, there's the actual amount that you're eating. And so we want to, yes, restrict calories, but the vast majority of patients that I see for metabolic health reasons are also not getting enough protein, and which is the most satiating. And if you're using whole foods, then you've got a more fiber and water content in the food that you're eating as well, which is also more satiating. So I always give patients protein targets to hit and spend a lot of time talking about how they can actually do that. And that alone, plus eliminating your soft drinks and like the easy low-hanging fruit, like do you eat cookies, chips, baked goods, refined carbohydrates? Do you drink pop? Do you drink alcohol? Like get rid of all that crap and people like will literally lose like 5 kilos by the next time you see them. And then you start to talk about how do we implement like good quality stuff. So that's the quantity. And then the timing is the time restriction or intermittent fasting piece. And you kind of just test the waters a little bit. So it's like, okay, well, how do you feel about restricting within a day? Or how do you feel about potentially longer fasts as well, as long as it's medically appropriate for that patient? So it's a lot of conversation to unpack for people. It takes a lot of time in clinic, but I've seen really, really great outcomes as a result of taking that time.
I think downstream, we also have to think about, if we implement all these things, do we really want a 90-year-old Mrkobrada hanging out with us on CTU? I don't know.
And he will be on CTU well into his
be on
nonagenarian years. Absolutely. Yeah.
On my SGLT2.
It'll just be his head on like a robot body. Yeah. Very unsettling.
Thanks for that.
Okay. Any last comments or questions from the group?
That was fantastic. Thank you, guys.
Awesome.
Thanks.
All right. Well, thanks everybody. And yeah, stay tuned for future dates. And again, if you have recommendations for articles, or if you would like to present an article, I would love to not have Marko present an article every single time.
I would love that. Just hang out. I can make some coffee. It'd be great.
Exactly. All right. Take care, everybody.